Sorry, sir. Good evening. You are mute. Can you please unmute yourself?
Good evening. Very good day. Yes.
Yes, sir. Should we begin, sir?
Yes, please. Please.
Okay. So, with the permission of the chair, Professor Indrajit Singh Sodhi, the professor and head Department of Public Administration, Rajiv Gandhi National Institute of Youth Development, Shri Peramadur, India, I hereby begin the presentation session 1. The co-moderator with me will be Dr. Meera Rajiv Kumar. So, Madam, are you there?
Yes, sir, very much.
Okay, so on behalf of the organizing committee, I welcome all of you to the presentation session 1. The theme of the session is the current trends in public policy and public administrative research. Yesterday in the plenary session, a good number of scholars and experts, they delivered their views and ideas and gave a direction to the conference. Today we will be following the same direction and we will be presenting our papers on the theme current trends in public policy and public administration research. So on behalf of the IPAN Foundation and the entire team of the conference, I welcome all of you. I would also like to express that due to the heavy rain, our co-chair, Professor Prakash Chand, Professor and Chairperson, Center for Study of Law and Governance, Jawaharlal Nehru University, New Delhi, India, is not able to join our session. So Professor Sabu Thomas will be replacing him as co-chair of the session. Now I would like to request Dr. Meera Madam to express her views on the current trends in public policy and public administration research and set a tune and objective for the session. Madam, the floor is all yours.
Thank you very much, sir. It is indeed an honor for me to be present here. First and foremost, it's absolutely wonderful to see Sodhi sir and our chair for the day, and also Professor Sabu Thomas, who is a co-chair, and of course yourself, Dr. Saurabh, for being present here. It's indeed a privilege for me to be here and be amidst this wonderful conference that is happening. And thank you for calling me as a moderator also. And I find this topic to be quite interesting. The topic speaks about a lot of things. That's the complete theme is on the current trends in public policy and public administration research. And what we have chosen today is about exploring the policy innovation and how the sustainable governance is actually changing the world, and what kind of innovations in public administration can navigate a big transformation. So this reminds me about how the evolution of public administration took place. When we see, all of us talk about how Woodrow Wilson was a father of public administration. But beyond that, I always think about the Indian father of public administration, Kautilya Arthashastra, Kautilya, and he has given in his treatise about the various aspects of administration also. And beyond which, later on, we had Woodrow Wilson, who has come up with a lot of stages, the formulation of various stages, which speaks about the principles of administration and the challenges that are present there, and how the principles can, what is the crisis identity? Because public administration, as it is, had to evolve as a separate discipline. So we had all these stages with the completion of public administration as a separate discipline. So that is something which is, we have crossed a phase of evolution, and today we stand class apart from various other disciplines also, because without public administration, we say that though Woodrow Wilson has stated there is a dichotomy between public administration and political science, but today I feel that it goes hand in hand, because policies, when we speak about policies, we require the help of the politicians also, plus we require the help of the administrators also in implementing it. When you see about the public policy as such, we have various kinds of models given by David Easton. We have models pertaining to the rational decision making. We take in the administrative thinkers like Herbert Simon, who's brought in the rational decision making over there, and then institutional model. So incremental model, of course, yes. So we have all these policies through which we can develop our very own model. We can develop our very own set of models where we have to bring in the outcome for or an impact in the society also. And this is about how public administration, because since our topic speaks a lot about the public administration, the current trends in public policy and public administration, what kind of innovation. So ultimately, we focus on the sustainable governance, sustainable goals. The achievement of the sustainable development goals is what ultimately we focus on. So for the attainment of the sustainable development goals, we require good governance also. Governance matters a lot. Good governance can be accompanied by new public administration and management principles here. So that's where we bring in a lot of e-governance methods also. So e-governance it has a great impact on the society too, where people have, when you can see after the pandemic, all of us have gone through this digital revolution and still we are going through. So that is why we can see I'm from a different state, Dr. Saurabh is different state, Sodhi sir is from a different state. So all of us are different states, but we get connected through this digital method. So this is something wonderful that we are getting into. So when we are able to achieve such kind of targets, why not? Why not? We have a good educational system also in future. So that matters a lot. And that's why we need to assess our national educational policy again in the forthcoming years. So this is something about when we focus on the policies, we need to have a revamp, a refinement of the policies as such based on the administrative principles, right? Like we have studied about Aristotle's political theory. We have studied about Confucius theory. They all wanted a kind of a social harmony, a virtuous act in the government that is essential. So we need to focus on all these aspects to bring in the attainment of a good administration. And when we focus on the sustainable development goals, we have almost 17 goals and 149 targets which we need to achieve. So we have crossed the millennium. Whatever was not possible to be achieved in the Millennium Development Goals, we are getting into the sustainable goal. So today's topic is very much relevant. I can say it is quite relevant to the present scenario where we are into a lot of policies. Now, today is an era of a lot of innovation setups. We focus on a lot of startups today where the government is ultimately focusing on Atmanirbhar or Make in India. So innovation techniques, because unemployment level or the trend of unemployment level is going very high. There's a steep rise in the unemployment level, especially after the pandemic. And you can see, you must have been hearing a lot of news about the layoffs of people, retrenchment happening all the way. So when such a situation is there, we need to provide employment opportunities for the youth today. So when we have to provide them with such kind of an opportunity, we need to give them a creativity because all of them are Gen Z kids. So Gen Z kids are more into digitalization. They focus more on digital techniques and tools. So ultimately, they will be more creative. There'll be a lot of creativity, a lot of innovation which is actually required. And so government today is offering a lot of seed money to encourage this kind of a system, which is again a kind of policy innovation that is happening. So we are all ahead. We are all towards the future, which is focusing on the sustainable governance because the world is changing. A lot of issues are happening all over the world, but ultimately the entire nation works for the attainment of the goals. So, and though we have a lot of complex situations or complex issues that are prevailing, right? So it can be in case of management, the techniques, and in case we have many other problems that are existing in the administration scenario. And so we require a good transformation. There needs to be a transition also in such kind of a system. So we are going towards such kind of a future where we can achieve the sustainable development goals. So this makes me ultimately to invite our chair, Professor Inderjeet Singh Sodhi, to speak few words on this particular topic, after which I also invite our co-chair, Professor Sabu, to speak few words on this, and then we proceed with our topic. Thank you so much.
Very good day, all the delegates. Thanks, Dr. Meera. This is the second day. So I believe that today everyone will look into policy from the perspective of innovation. So I have gone through some papers are relating to health and other allied areas. So when we talk about innovation, innovation definitely means something new. That is, most of innovation is taking place on the policy design, because when we talk about policy, there are many aspects, whether it is a policy formulation, policy design, policy evolution, policy implementation. But it is being believed, and we have observed, most of the innovation is taking place on policy design. And there have been one great thinker, Christian Besson. In one of his book that is on the frontiers of design, that was published in 2017, in that he mentioned about some few aspects which look into the facing complexity. Similarly, there is a shift from
Sir, you need to unmute, sir.
problem oriented. I am on mute. Whether
Now you
hello,
are.
I am.
Now you are audible, sir. Please continue. Thank you.
Okay. So I was mentioning, Christian Besson has focused that there is a trend or shift whenever we talk about innovation in public policy, from problem oriented to vision oriented, reactive to proactive, unilateral action to shaping new alliances, facilitation to stewardship, strategy. When we talk about strategy, so rather than strategy, Christian Besson talk about impact emphasis. Similarly, rather than resisting complexity, if any there is a problem, we resist or we deviate or we run away, rather than we have to accept, embrace the complexity, and we have to move through. So it depends upon how much steps innovation we are doing regarding the structure, regarding the function, regarding the program, regarding the strategy. So we all have to look into that. And when we talk about policy innovation, it is not a, we could say, easy task. Definitely it requires so much expertise. Still, if we see at the world level, there are very few experts who could work or who are working definitely on the policy innovation. So I believe that today some papers will throw some light on innovation in their respective area on which they are focusing on. So I am thankful to my colleague, Dr. Saurabh Chandra, who has taken initiative. And today, Prakash Chand was co-chair, but due to heavy rain in Delhi, he has been stuck in one place. Even he has not reached home. So as we know, in North India, whether it is Himachal Pradesh, Delhi, Rajasthan, Punjab, Chandigarh, Uttarakhand, everywhere there is so much, we could say, torrential rain in some places. Even I was in market just now, I reached, that's why I became late to join, because some places has been closed, there have been barricades due to so much rain. So these all natural always play its role, but we as a human have to go through all these aspects. So I believe today's session will be very relevant and lively, and we will learn a lot of lessons. Thank you. Thank you, Dr. Meera, for moderating.
Thank you, sir. I think the insights are well taken, sir. And we shall proceed further with inviting Dr. Sabu, our co-chair for today's session, to speak on this particular theme for the day.
Thank you, Meera. Am I audible?
Yes, sir, you are audible.
Yeah, thank you, thank you. So, well, it's the second day of our 5-day international conference on challenges on public policy and public administration. And I feel that this is the right time to debate on the serious issues. So, I was hearing the introduction from Meera. She was talking about the UN initiatives. And I remember that in 2001, United Nations, when they started debating on Millennium Development Goals, they have established a committee of experts on public administration to find out the means to improve the quality of governance. And they believe that by these attempts, UN can attain these goals by improving public administration. So they established a committee of 24 of the world's most distinguished experts in the field of public administration. And they are working on the various modalities, particularly on public sector governance, how to improve public sector governance to attain the Millennium Development Goals. But well, the committee has done a lot of things initially, but when we moved from Millennium Development Goals to SDGs, the role of public sector, particularly public administration, was very much missing in the debates. It has been taken as far as I know, it has been taken as a purely political agenda, or maybe that kind of a mechanical kind of thing. So the role of public administration, particularly in the operation of these goals, is very much missing. So that's why I'm telling that the world is to understand, the academic circles and the policy circles has to understand and think about a structural public governance model, which has to address the major issues of or major goals of the SDGs. So yesterday we were talking about the digital revolution, and in my keynote address, I was also mentioning about the age of ChatGPT and deep learning. So these issues was a great challenge to public administration, and I feel that this is not only a challenge, this is also an opportunity to improve the sector, the public sector. So I've seen that there are a few papers on this topic also. So we will get ample venue to discuss on these serious matters. And I hope that our deliberations will result in maybe in fruitful policy outcomes. So we are waiting for the presentations of the day, their inputs, their observations will make this conference a great event. Thank you, Saurabh, and thank you, Meera, and thank you, Sodhi sir. Over to you, Meera. Meera, over to you.
Yes, sir. Thank you so much. Thank you so much. And I'm sure today's participants will have got few points from the speech from both our chair and co-chair also. So we will move ahead with the session. So let me call out the name of the first presenter. So shall we go ahead, sir? Sodhi sir, shall we proceed?
Yes, proceed. Yeah.
Okay, so fine, thank you. Okay, so the first paper presentation will be by Dr. Vijayata Sharma, Associate Professor, Public Policy School of Behavioral and Social Sciences, Manav Rachna International Institute of Research and Studies, Faridabad, Haryana. And her topic is on maternal health in Punjab, policy response to postnatal care interventions under Janani Suraksha Yojana. So I hand over the platform to Dr. Vijayata Sharma to start. You have, after which our chair or co-chair may question also.
Good afternoon, good evening, everyone. I'm just loading my presentation. Is it visible?
Yes, it is visible.
Yeah, so the topic of my presentation is maternal health in Punjab. So I've written a policy response to the postnatal care interventions under the scheme that is Janani Suraksha Yojana. As we know that maternal health is a very significant concern, not in Punjab or India. It is a very important concern all over the globe. And as we see, the postnatal care interventions are very less. The people are going for ANC, people are going for delivery care. There has been increase in institutional delivery, but still there is a lack in the postnatal care over all the globe. So I've written a policy response for that. So there are certain guidelines by WHO. So WHO provides to restore, maintain, and improve the health of women during pregnancy and after the critical phases of childbirth. And they are very important critical actors called community health workers, that are the ASHA workers. They provide a very prominent role improving the maternal health. And then we have a scheme called RMNCH plus A, that is reproductive maternal newborn child health and adolescence. That is a very comprehensive scheme under the National Rural Health Mission, which covers the overall umbrella of maternal, newborn, and the adolescent care in the rural areas as well as the urban areas. And if we go back to date back to the starting of the maternal health care and the healthcare intervention, there was a Bhore committee. So it was set up in the year 1946 during the time of our independence, and it provided a discrete setup of the healthcare systems all over the country. So a structure of healthcare system was set up at the district level. So we have district hospitals. At the block level we have community health centers. Then at the we also have at the village level we have primary health centers, and then we have the sub centers, which are the grassroots level healthcare service organization providing services to the people. So it was set up at the time of independence only. But still we know that the incidence of maternal mortality is very high in our country. It is very high in the low and middle income countries as well. So the maternal mortality rate accounts for 96% from the lower and middle income countries. So the developed countries, they contribute only like 6 to 7% of the maternal mortality rate. And Africa is one of the country where the maternal deaths are very high. So 1 in 39 women, they die in the country called Africa. But there was a significant improvement over the years. There was a decrease of only 38%, and still the maternal mortality is very high. And as we know that the postnatal phase is very important, so day 1 to day 42 counts for the postnatal health care. And during that period only, the maternal mortality and morbidity rates, they are very, very high in our country. So we have MDG 5 and SDG 3 that provides for the maternal health. MDG 5 provides for reduction in the maternal mortality rate, and MDG 5B, it provides for universal health, universal access to reproductive care. And SDG 3, later on in 2005, the MDGs were converted into the SDGs. So SDG 3 provides for improvement of the maternal healthcare outcomes in the country. And now we see that there is a very important scheme called Janani Suraksha Yojana. So it was initiated in the year 2005 when the National Rural Health Mission was started. So NRHM is a comprehensive umbrella program. It comprises of all the programs like maternal health, child health, nutrition interventions, disease control programs, development of the infrastructure. And JSY was initiated during 2005 only, when the NRHM was started. So under the JSY scheme, the cash incentives are given to the beneficiaries. So if they go for delivery at the health center, they get the cash incentive. And under the scheme also, they also provide, they are also given like ANC checkups, PNC checkups. So as I said that ASHA is a very prominent health worker, they link the beneficiaries to the health center for getting the desired services. So postnatal care, it accrues a significant place in the health of women because it is one of the new phase after the childbirth, and as they require proper recovery to regain strength, as they need to contribute to their family, to their society, they also have to adjust to the life with the new being and for having future birthing experiences. If we see the literature, there are very limited studies on the postnatal care. Most of these studies are on ANC or they are on the delivery care interventions, or they are on the comparison between the ANC, PNC. But most of the studies are in the ANC and PNC area only. And the geographical.
Madam, I think you'll have to flip the slides. Slide is stuck into the first one.
Ma'am, I'm like flipping myself.
Yes. Now it's a research objective which is seen. Fine.
So is it coming postnatal care,
Yeah,
ma'am?
yeah. That is seen now.
Okay, and the studies are very less in terms of geographical area also. Most of the studies are concentrated in the African region, and other regions are not covered very much in the research literature. And there are some studies which are relation to the ANC and PNC. If the ANC rates are higher, what would be the PNC rate? So it has been seen that the women, they are going for the ANC, but they are not going for the PNC in certain regions, while in certain parts of the country like West Bengal, ANC, PNC, both are good. So some significant concerns also emerged, that the hospital-based care and the home-based care. So for that, no significant guidelines are there, like for the hospital-based and home-based care. It is there, but a proper guideline mechanism is not available. And then there's inequities in the postnatal care that has been seen in the literature. So some women are getting postnatal care, they are getting a nutritional interventions, they are getting other benefits like the counseling from the ASHA workers. But there is also a linkage, like if the caste of the ASHA is SC, so she is giving more counseling to the women who are SC and not like bothered about the other women. And another concern was the knowledge of postnatal care were very less among the women, because there's a kind of a cultural concerns that go around. So people like following the traditional remedies during the postnatal period, and the women, they don't like going outside their house for 1 month or so, like so that kind of concerns were there. And mental health was also a significant concern in the area, because sometimes it's a new birthing experience for which they need counseling from the ASHA or the doctors. So that was not given. Sometimes their child dies, so that was also seen. So these kind of concerns were there. Then mortality and morbidity, it was also there during the postnatal phase. So the my research objective is to know the satisfaction of maternal health beneficiaries with the postnatal services provided by the health center. I also studied the contribution of community health workers in the postnatal care. Then the study also found the perception of the medical and paramedical professionals, that is the doctors and the nurses, with the discharge of postnatal care services at the health centers in Punjab. The study employed an exploratory research design. So in the state of Punjab, I selected 2 districts, that is District Ropar and District Mohali. As we know that the Punjab is a non-high focus state, in that I selected 1 high focus district and 1 low focus districts. So under NRHM, there are certain guidelines which divides the districts and the states into high focus and non-high focus, and they have made an index regarding that. So I applied probability proportionate to size sampling, and I selected 232 JSY beneficiaries and 40 medical and paramedical officers equally from both the districts. So a research technique that I applied was semi-structured interview scheduled. Then I applied the chi-square test to know the association between the different variables to draw the appropriate conclusions. And then I provided a model response policy to accelerate the maternal health care in the state of Punjab. So this is the demographic profile of the JSY beneficiaries. If we see that most of the beneficiaries, they lie between the age group of 25 to 30 years. Most of them had the secondary level of education, and they belong to the household income of 15,000 to 20,000, and most of them were belonging to the scheduled caste category. And this is the demographic profile of the medical professionals. So I select so 20 medical professionals were selected from both the districts, And most of the medical professionals in the state of in the district Ropar, they belong to the primary health center, and in the district Mohali, primary health center and the sub center. So we have three categories of officials, that is ANM. ANM sits at the sub center and also at the PSC, and the staff nurse and FMO, they are available at the higher level health centers, that is the PSC, CSC and the district hospitals. So my first question was the satisfaction level of JSY beneficiaries with the postnatal care. So it has been seen that the beneficiaries, they were not very much satisfied with the services provided by the health center, the postnatal services. So under the provisions of the scheme, the ASHA, she has to make a visit to the beneficiary's household within the 7 days of birth. So, and there are 4 PNCs that they have to cover under the JSY scheme. But it was seen that the they said the ASHA workers, they were visiting them, but they were not happy with the services provided at the health center. So they prefer not going to the health centers and just depending upon the other family-based provisions that they had at the health, because they said that when they go to the health center, the most significant concern was that the doctors were not very serious to look at the postnatal care patients. So they believed that the delivery care is done. So they believe that the provision of the scheme is still the delivery care only. If they are coming for delivery to the health center, institutional deliveries rates are rising and it is like okay for them, and they were not treating them very properly. They have to wait for a long time, and then they were very much curious about like serving the ANC patients, like not the PNC patients. So that kind of attitude was there among the doctors and the paramedical officials. So they prefer not going, and this is a kind of a word of mouth that goes around in the entire village and the region. And again, the provision of nutritional supplements like the calcium, iron and folic acid tablets, that was also not there. So they get restored and they get also finished very quickly in the health centers. So they believe that there is no reason of going for the PNC checkup. So that was the main concern, that JSY beneficiaries were dissatisfied with the postnatal services. However, with the support and counseling provided by the ASHA, they were very much happy. So ASHA was providing a visit to the households. So under the guidelines, ASHA is provided with the specific guidelines. So is visiting the beneficiary first day, 7 day, 10 day. So there are days for which the ASHA visits the postnatal woman. So they were very much happy with the ASHA's response, because ASHA is the person who stays in the village and who belongs to their community, and she's just one call away from their house, and they can immediately call her and talk to her at any time which they want. So there is a kind of a trust element which was developed among them with the ASHA. And she was also providing appropriate referrals to health centers. She was going to them and telling them which health center for delivery they should select, and if there's a postnatal complication, which health center they should go, depending upon the availability of ANM or the doctor in that particular health center. Because ASHA keep visiting the health centers, and ASHA also keep visiting the beneficiaries. So they were very happy with the information and the care protocols provided by the ASHA to them. Then the satisfaction of medical and paramedical professionals with the discharge of the postnatal care. So the medical officials, they also had certain reasons that why they are not happy with the discharge of the postnatal care. According to them, they are having no nutritional supplements. So iron and folic acid and calcium tablets, they always remain scanned with them. So they say that the beneficiaries are not visiting because there is no medicine to them, and there is a kind of a cultural element going around in the villages. So that is the main reason. And there is also least incentivization by the government, no awareness campaigns by the government side to go to the beneficiaries and tell them the importance of postnatal phase, which is a very crucial. And shortage of nutritional supplements is there. So this is the main reason given by the medical officials. So in order to curb all this and to improve the postnatal care in the state of Punjab and all over the country, so I have proposed a model policy for the augmentation of postnatal care. So I have proposed some institutional measures, some socio-psychological measures, and then there are certain policy channelization measures which are applicable to both these kind of measures to bring about effective postnatal care. So in the institutional measure, the hierarchical structure should be strengthened at all the levels. That is, the provision of infrastructure, provision of doctors should be made available in as per the guidelines which are given by IPHS 2012. And another concern is the timely referrals. That was also the major concern, because sometimes the women, they are requiring care. They go to one health center, the doctor is not there. Then they go to another health center, maybe infrastructure is not there. So that kind of provision should be made in the guidelines, so and strengthen the structural arrangement, so that the women, they don't have to go from one health center to another health center in order to seeking for care. And ASHA is the link worker who can help in solving all these issues. Another institutional measure is the technological factors. So they will help in timely, phase, systematic, and efficient achievement of health targets. What technology do? It lends explainability at all the levels in the organization. So, certain kind of matrix should be made, in which the databases should be put in that matrix, and then they can be utilized, checking that these are the ANC visits at this health center, how much would be the PNC, who are the beneficiaries who are coming, who are not coming, and then they should be given some specific counseling, going to their household, group counseling sessions. And at the national level also, there should be kind of a database, so that the message should directly go to the beneficiary. So that kind of thing should be developed. So personal factors should be strengthened. That is the mandatory postnatal visit by the ASHA and ANM to the household. Sometimes ASHA are already going to the household, but ANMs are not very much interested in visiting the household. But ANM know more about the medical protocol. So ANM should go to the household and check the postnatal woman. If there are some complications, she should herself refer them to the health center or the doctors. So the intelligible advice, extra visits, and timely medical assistance and strengthening of medical assistance at the health center is very crucial. And then the health officials, they should be present at the health center during their regular duty hours, performing the quality checkups, because it has been seen that at many of the health centers, the doctors were not available, they were on long leaves, or they often come like without giving any notice. So that thing should be strengthened among the personal factors. Then the availability of equipment, medicines, and other consumables like the test tubes and other things, they should be made available at all the health centers. Then there are some socio-psychological measures which should be strengthened. There is a need of a behavioral change interventions, that is the counseling modules, that should be developed and should be strengthened, incorporating the cultural and location-based behavior modification measure, because as we pass 2 or 3 villages, the culture changes. So that should be very much incorporated into the policy. The role of family, NGOs, panchayat should be taken care of. Like panchayat plays a very important role in changing the behavior. So panchayat can guide the ASHA and the others, panchis and sarpanchis. They know everything about what is the local governance going around, what is the main political viewpoints of the people and other things. So they should be taken care of, like while developing the behavioral change interventions. And then there should be certain kind of strategies to curb the rigid cultural traditions or anti-clinical care attitude among the beneficiaries or the rural people. Then there should be coordination and communication among the health staff. So there should be certain guidelines in which we should know that when are ASHA and ANMs meeting, when the ASHA meeting the medical officials, when the ANM is meeting the medical officials fortnightly, monthly, or weekly. So there should be certain guidelines set for that. So matrix structure of meeting should be developed. And then beneficiary and the health staff relations should be strengthened, and that is on the basis of trust and care based on compassion, how the doctors, they are treating the patients. So only only for that reason the patients, they will go to the doctors. And there should be a copious crafting of supply side behavioral attributes among the health staff. And then I also propose a mental health cell at the PSC level, because at times there are morbidity and mortality cases which the woman takes very seriously, and many times the family environment is not very good, it is very rigid. So mental health cell should be there, where the counseling, a proper clinical counseling to the beneficiaries should be given. Many times they're having loss of newborns, or they're having long morbidity periods, so that would really help. Then I propose certain policy channelization measures. So it should be seen what kind of approach the government is following, particular policy, what kind of approach should be there, what are the nature of the constructs, formative and or reflective, what are the different research paradigms. So all this should be properly integrated into the while formulating the policy and deciding what decisions would be taken, what are the structural and social psychological measures. They should be very integrated into that. And there should be alignment of political and bureaucratic processes with the research agencies, think tanks, and mandates given by the international organization. Another is the outcome measurement strategy. The adoption of legit outcome measurement strategy indicating progress, survival, lapse, or hibernating phase of policy implementation, and attainment of outcome is the key to attain the intended objectives. Then feedback, evaluation, and absorption. Feedback received by different stakeholders at different level of policy execution platforms, and how it is taken into the policy. So how it is effectively achieved. So that should be given, because feedback is there at all the levels, but it is not getting absorbed. So it remains like that. So at what level of the policy, what level of the structure, the feedback should be taken and incorporated. That is very, very important. Then is the performance evaluation. The performance evaluation is a post facto activity, but it is very important in knowing what we can do in the future. So what changes we can make in the desired outcomes, goals, and objectives which are enshrined in the policy document, that we can always incorporate doing a right performance evaluation at the right time, at the end of the policy, and also between the different phases of the policy implementation. So it will really help in detecting the anomalies and bridging the gaps for the future plans. So these are the three measures that I suggest for effective postnatal care. So in the end, we can say that all these three measures, they should be meticulously planned and amalgamated to bring to curb the low response of postnatal visits by the beneficiaries, and also to improve the service discharge at the health centers by the healthcare officials. So the institutional factors, they play a crucial role in maintaining the status quo of the current provisions and providing services to the people. The socio-psychological factors, they are essential to aid the delivery of services and provide a modicum for the smooth and harmonious achievement of health targets. And the third, the policy channelization measures, which are very crucial. They provide fulcrum to the entire machinery for effective discharge of services, and they also lend momentum to the constantly occurring phases in the policy implementation process. So when all the three important measures, they are integrated, they are surely to bring about the effectiveness in the postnatal care. So I think all this should be integrated, and we should also formulate a policy particularly on the postnatal care of the woman. It should not be at the between the it should not be part of the JSY, but it should be a separate policy at the national level for the postnatal care. Thank you.
Thank you, Ms. Vijayata Sharma. It was a nice presentation. And Sodhi sir, Sabu sir has told that we can have the questions at the end of the session. So can we go that way, sir?
Yes.
Or would you like
yes,
to?
Yes, we can go later. Yeah,
oh.
We can note down at the last. No issue.
Okay, sir. Fine, fine. Thank you, sir. Thank you. So the participants, please note the questions will be posed at the end of the session. So we go to the Next participant for the day, we have the paper presentation by Neha Katoj, research scholar from the Department of Public Administration, Punjab University, Chandigarh, Punjab. And her topic is on evaluation of the Pradhan Mantri Matru Vandana Yojana, addressing maternal health and empowerment. Madam, you may please start your presentation.
Good evening, everyone. Am I audible?
Yes, you are.
Okay, so good evening, everyone. I am Neha Katoj from the Department of Public Administration. I am pursuing my PhD there. And today I am going to present my paper, and the title of my paper is Evaluation of Pradhan Mantri Matru Vandana Yojana, which is a maternity benefit program, and I will be addressing the maternal health and empowerment. So in this paper, I will discuss about, first of all, introduction, then about the a little bit about the historical background, then the aim of the study and the adopted research methodology, overview of the scheme, that is about the targeted beneficiaries, what is the aim of the program, and what are the benefits of the program. And another is this is also in the overview of the program, that is the Pradhan Mantri Matru Vandana Yojana 2.0. And next is the evaluation of Pradhan Mantri Matru Vandana Yojana scheme, and I will evaluate the maternal health and women empowerment. And next will be the strength and limitation of the program, and then conclusion. So first of all, introduction. The issue of malnutrition is a major health problem in many developing countries, including India. It has a major impact. It has a major negative impact on the health of mother and the newborn child. As per the data released by the National Family Health Survey 5, around more than 50% of the pregnant women are anemic in India. And this anemia and malnutrition are the major factor which is contributing to the health loss in India. And this is basically due to the fact that undernourished mothers are responsible for starting the cycle of the undernutrition in the newly born child. So it is very much required to focus on the antenatal and the postnatal care. Now the historical background. So first of all, in 1997, the Reproductive Child Health Phase 1 initiative was introduced, and the main focus of this Phase 1 is maternal health and child health. Maternal health was mainly focused on antenatal care and postnatal care, and child health is all about child health, nutrition, and vaccination and immunization. And then in 2005, National Rural Health Mission was introduced along with the Reproductive Child Health Phase 2. And the major focus of the Reproductive Child Health Phase 2 was institutional deliveries, skilled staff attendance during delivery, and the policy decisions. So along with RCH2 and National Rural Health Mission was introduced, Janani Suraksha Yojana program was also introduced, and it was launched by Ministry of Health and Family Welfare. And next in 2010, maternity benefit program, which another maternity benefit program was launched by Government of India, which is Indira Gandhi Matritva Sahyog Yojana, and it was launched by Ministry of Women and Child Development. And then in 2013, National Health Mission incorporated National Rural Health Mission and National Urban Health Mission. And then in 2017, few modifications are done in the Indira Gandhi Matritva Sahyog Yojana, and this program was renamed as Pradhan Mantri Matru Vandana Yojana. Now the aim of the study. In this paper, I have evaluated the effectiveness of Pradhan Mantri Matru Vandana Yojana. I have shed the light on successes, difficulties, and potential improvement areas of the program. And the research methodology that I have adopted is I have gathered the data from the secondary sources, and I have secondary sources such as academic articles, government reports, policy documents. I have evaluated those data. Now the overview of the program. So Pradhan Mantri Matritva Vandana Yojana program is the flagship maternity benefit program, which was introduced by Government of India in 2017 under the Ministry of Women and Child Development. And it provides financial assistance to the pregnant and lactating mother for their first delivery. In compliance with National Food Security Act, it is introduced in all the districts across the nation. And it is 100% sponsored by the central government. And the major goals of the program is supplying nutritional supplements for women during pregnancy and breastfeeding, which is in compliance with the National Food Security Act, and offering partial economic incentive to make up for the lost wages during the pregnancy. Now about the I will discuss about the payment pattern and the eligibility conditions. So the payment is done in the 3 installment. For first installment, the condition is the pregnancy should be registered within the 150 days. And in second installment, for second installment, the condition is at least one antenatal checkup should be done. And for the third condition, for the third installment, the childbirth should be registered, and the first cycle of the immunization of the child should be done. So all the record of antenatal checkup and pregnancy record and childbirth, child immunization is kept or mentioned in the mother and child protection card, which is issued by the ANM at primary health center. And the amount is 5,000 rupees. And additional 1,000 rupees is also transferred to the account of beneficiary for the nutritional support. Now the targeted beneficiaries. So the targeted beneficiaries are the all pregnant and lactating women, except the women who are the regular employees of central government, state government, PSU, or the ladies who are availing a benefit from some other scheme like Janani Suraksha Yojana or some state sponsored scheme. And all eligible pregnant women and lactating mother who become pregnant for the first time on and after January 1st, 2017. Now the Pradhan Mantri Matru Vandana Yojana 2.0. In previous year, this scheme is clubbed with the Mission Shakti Samarthya sub scheme, which is also under Ministry of Women and Child Development, and few modifications are done to the scheme, and the scheme was renamed as Pradhan Mantri Matru Vandana Yojana 2.0. So the modification is in previous scheme, it was the beneficiary can take the benefit only for their first delivery, but in this scheme 2.0, beneficiary can take the benefit for the second time. But the condition is if the second child is a girl child. So there are objectives are first two objectives of this scheme are also the same with previous scheme, but additional objective is to promote the positive behavior toward the girl child. And there is also change in installment pattern. So in the previous scheme, the installment was done in payment was done in 3 installment, and in this payment will be done in 2 installment. First and second installments are clubbed, that is registration of pregnancy, and first antenatal checkup is clubbed in the first installment, and second installment will cover the childbirth, registration of childbirth and the child. Now the evolution of scheme. So first we will discuss about the maternal income. So in first I will discuss improvement in the access to natal care and natal care. If we compare the figures by National Family Health Survey 5, it is quite evident that there is a improvement in the access of antenatal care and postnatal care during as we can see in the table. The antenatal care during the first trimester was in 2015-16 was 58.6%, and in 2019 to 20 it was around 70%. And also with the registered pregnancies and NFHS 4, it is around 90%, and in NFHS 5, it is around 96%. Now the reduction in maternal mortality. The maternal mortality in India is decreased from 113, that is in 2016 to 18, to 103 in 2017 and 19. But still, maternal mortality is quite high in few states, as we can see the red area, which are the states like Assam, Madhya Pradesh, Chhattisgarh, Bihar, and UP. In these states, the maternal mortality rate is around 130, which is against for every 1 lakh live births. Now, if, the nutritional support status, so numerous steps has been taken by the government of India, like Poshan Abhiyan and midday meal scheme, but nutritional status among the women and children is still gruesome. According to data released by, as I have discussed this earlier, that more than 50% of pregnant women are anemic, which is leading to the anemic infant and major other vitamin deficiencies in newborn child. Promotion of institutional deliveries. So I have compared the data of NFHS 3, NFHS 4, and NFHS 5. So we can see clearly in NFHS 3, home births was around 59%. But in NFHS data of NFHS 4 and 5, home births are significantly reduced to the 4.3% and 3.2%. Now the empowerment of women. So financial support and economic empowerment. So this maternity benefit program, Pradhan Mantri Matruta Vandana Yojana, is a direct benefit transfer program. It allows the transfer of money to the pregnant women account directly, and it provides partial compensation to the pregnant women and lactating mother for their lost wage that they have suffered, and awareness and education. So there are some conditional eligibility for the beneficiary. So as I have discussed that for the first installment, there should be a pregnancy should be registered, and for the second to get the avail the second installment, at least one antenatal checkup should be done. So I mean, it is quite evident that for the registration of pregnancy and for antenatal checkup, pregnant lady is visiting the Anganwadi center or PHC at least twice or thrice. So by this, they are actually getting the counseling, and they're actually getting the information from the Anganwadi worker, Asha worker, and ANM. So it highlights the value of institutional birth, regular checkup, and appropriate eating. And also by awareness, by regular checkup, there is high chances of prevention of high risk pregnancies. And as I have discussed, for the third installment, the proper immunization is necessary. So it also ensures the proper immunization. And now the decision making and autonomy. By giving women financial freedom and empowering them to make decisions about their own and direct child for their children health, Pradhan Mantri Matru Vandana Yojana gave women the power to take charge of their own life and their child health. Social and community empowerment. By creating the awareness about maternal health, Pradhan Mantri Matru Vandana Yojana is bringing behavioral change in society. Also providing the second time benefit of the Pradhan Mantri Vandana Yojana only to the girl child is discouraging pre-birth sex selection and is encouraging honor and celebration of the birth of girl. And the motto of the slogan of the scheme is Matra Shakti, Rashtra Shakti. Now the strengths and limitations. So strengths of the scheme. I have already discussed about the financial assistance to compensate for wage loss. Now the greater coverage. There are few other maternity benefit programs like Janani Suraksha Yojana. In Janani Suraksha Yojana, there are few conditions like the women should be from BPL family or from the or either SC or ST. But in case of Pradhan Mantri Matru Vandana Yojana, there is no such condition like BPL or SC ST. It is open for all the women except they are working in there are regular employee of central or state government. So yes, the coverage of this scheme is really high. And conditionality to promote healthcare seeking behavior. So this scheme to get the installment, you have to register your pregnancy, you have to at least go for one antenatal care check. You have to register your childbirth. You have to register about your child vaccination. So it promote healthcare seeking behavior. And the integration with other program, it is as per National Food Security Act, it is also integrated with the other programs like Poshan Abhiyan, like other programs of ICDS, and digital platform from tracking and registration. So Pradhan Mantri Matru Vandana Yojana program, in this program, the registration, cash transfer, tracking, everything can be done on digital platform, which improve transparency, reduce delays, and also ensure the effective monitoring. And the promotion of positive behavior toward girl child, I have already discussed for the second pregnancy. If the second child is girl, you can avail the women can avail the benefit twice. Now the limitations. Inadequate financial assistance. So the current entitlement of rupees 5,000 provided over 1 year amount to 1 month wage loss, which is not sufficient, and in line with the Maternity Benefit Act 1961, which mandate 12 weeks of maternity leave for women with 2 or more children. Pregnant and lactating mothers should receive 12 weeks of wage compensation, which is around rupees 15,000. And another point is about the cesarean deliveries. As per the data released by the NFHS 4 and 5, it is clearly evident that in private facilities, the cesarean deliveries, more and more cesarean deliveries are occurring. So, I mean, it is not a affordable affair in the private facilities, and it is a costly affair, which for this rupees 5,000 is not sufficient. Now the corresponding state specific scheme. There are many schemes like Odisha Mamta Yojana, KCR kit by Telangana government, Dr. Muthu Lakshmi Reddy maternity benefit scheme by Tamil Nadu. These schemes are providing benefit for 2 deliveries and financial incentives in case of KCR kit and Dr. Muthu Lakshmi Reddy maternity benefit scheme is much more than Pradhan Mantri Matru Vandana Yojana. That is why more and more potential beneficiaries are moving toward these schemes as compared to the Pradhan Mantri Matru Vandana Yojana, which is also the factor for delay in the enrollment and payment. As we can see that in 2020 to 2021, the Pradhan Mantri Matru Vandana Yojana, the enrollment of beneficiaries is decreased around for more than 52%. Now the conclusion. In the concluding remarks, I can say Pradhan Mantri Matru Vandana Yojana is playing a significant role in providing direct cash transfer to women, alleviating the financial burden associated with pregnancy and childbirth. However, there are challenges that need to be addressed. Inadequate financial assistance and implementation challenges such as delay in dispersing fund and bureaucratic hurdles need to be addressed to ensure timely and effective support to eligible beneficiaries. By continuously evaluating and improving the scheme, incorporating comprehensive approaches and prioritizing the need of women, Pradhan Mantri Matru Vandana Yojana has the potential to significantly contribute to the overall well-being and empowerment of pregnant and lactating women across the country. Thank you.
Thank you, Ms. Neha. I think that was a wonderful presentation. Initially, when I saw 21 slides, I was wondering how you would complete, but you were on time. Thank you for that.
Thank you.
So, yeah. So can we go for the next presenter for the day? It is Ms. Harita Swarup, ICSSR Doctoral Fellow, Department of Public Administration, Osmania University, India. And okay, this is a joint paper by Ms. Harita Swarup and Dr. Ravinder Kaur, Professor, Department of Public Administration, Osmania University. And the topic for the day is influence of socio-economic and cultural factors on women's health in India. So you can take over the platform, Ms. Harita.
Thank you, ma'am. Respected dignitaries, presenters, and all the participants, a very good evening to everyone. My name is Harita Swarup. Recently finished my PhD from Osmania University in the Department of Public Administration. Firstly, I would like to thank the conference organizing committee for giving me this opportunity to present my paper. My topic of the presentation is on the area of health, particularly women's health. We all know that health is an essential component in everybody's life. Health is not just a biological component, it is a socio-psychological aspect. So we all know the one good definition given by World Health Organization. World Health Organization defined health is a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. From this definition, we can observe that socio-psychological aspects are very important to observe the health. This definition motivated me to observe social dimension of health. So also, World Development Report 1993, it stated in its report, Investing in Health. Investing in health examined the interplay among human health, health policy, and economic development. So we can say that investing in health is the best investment. This investment should be distributed rightly. So I also observed that in a few articles, from few articles, that in women's, particularly women's health contributes for the economic development. For example, it with the increased labor participation, with increased levels of nutrition levels. So there are some benefits if we concentrate on women's health. There are positive influences if we concentrate on women's health. So overview, coming to my topic, overview of my topic, what I have presented in this topic. My presentation is mostly based on literature review, secondary data sources. So first I discussed introduction, second influence of different social factors, which included gender inequality, early marriage, education, caste, and third aspect is influence of economic factors, where I discussed employment, income. And fourth aspect is influence of cultural factors, gender bias, taboos related to food during pregnancy, and women's autonomy. So coming to introduction, health is an essential component of the well-being of all people, and it is necessary for the growth and development. In addition to other considerations, a community's health problem can be influenced by a variety of social, economic, and political factors. The community's health-seeking behavior is influenced by shared ideas, norms, practices about health and illness. So here I observed that there is a difference there. From each community to other community, health-seeking behavior is different based on their traditions, based on their customs. And especially when coming to women's health, pregnancy and child birth related deaths are more prevalent among rural women especially, and poor women's health and nutritional status in India are inextricably linked to socio-cultural and economic factors. Women's health gained prominence in India, notably after the International Conference on Population and Development in Cairo, Egypt, which was held in Cairo, Egypt in September 1994, and the Fourth World Conference on Women in Beijing in September 1995. So both these conferences prioritized women empowerment, women's health, and reproductive rights. Again, after both the conferences, India also adopted reproductive and child health initiative in 1994. All the interventions were adopted for controlling the fertility, mother and child health are included in this program. So the attention on mother and child health has been re-emphasized and strengthened with the introduction of the National Rural Health Mission in 2005. Healthcare behavior differs based on norms, values, beliefs, social taboos, food avoidance, and the other societal customs and practices. Here in this paper, I would like to, I presented a few viewpoints where maternal health is observed in relation to the influence of socio-economic cultural factors. So coming to social factors, influence of social factors. In social factors, based on the literature review, I observed that Gender inequality is one of the factors which is contributing to women's ill health. So what are the reasons for gender discrimination? There are different regions. It is different from community to community. Religious beliefs, educational backwardness, caste, customs, beliefs, culture, unemployment, low income, family situation, society, and attitudes. These contribute for gender discrimination. As a result of this, health deteriorates over time because they lack the power to make choices and seek medical treatment, eventually deteriorating their health. Here I observe that gender inequality, means especially gender discrimination, can be observed as a health problem among women. Why it is observed as health problem? Because it have psychological effect on women. Psychological well-being is also one of the important aspect, significant aspect of health. So second aspect is early marriage. A young girl who marries is more likely to get pregnant, and they give birth when her body and mind are not yet ready for delivery, and where she is not ready for it. These young mothers face extremely high maternal morbidity and mortality rates, especially in India when compared to Asian nations. 26% of women gave birth before they were 18 years of age. So it is greater than in other Asian nations such as Philippines, whereas in Philippines it was 10% and in Thailand it is 8%. And third aspect is education, how education is influencing women's health and how it influences the women's health. Education, particularly women education, is usually seen as a crucial aspect in development. It is considered that women education has a significant impact on maternal and child health because it improves the mother's knowledge and abilities about nutrition, age at marriage, contraception, disease prevention, and treatment. Inadequate health education, poverty, improper eating habits, and illogical beliefs worsen the health and nutritional condition. I observed in my PhD thesis also there is a positive correlation between health and utilization of maternal health services. With the increased level of educational levels among women, there is an increased utilization of maternal health services. And the other aspect is caste. For instance, from few literature review, I observed that more economically privileged households receive institutional delivery services, that is 95%, than economically poor households, that is 59%. And there is a differences among different caste groups. 68% from scheduled tribes and 78% from scheduled caste and 80% from backward caste are accessing institutional delivery services, which is very meager, whereas 83% of women from forward caste receive similar facilities. So there is a differences between among the different caste groups. And the other aspect is influence of economic factors. First is employment. Occupation increases social status and influences health outcomes due to specific benefits accorded to individuals of higher status, such as more accessibility to better healthcare, accessibility to education, and housing accommodation. When women are employed, obviously they get they are financially freedom, and they can have decision making power in the family, and they can access more maternal health services. There is a positive correlation between employment and utilization of maternal health services, which I observed in my PhD thesis also. And income. Most individuals, most individuals and households get their income from paid work. Individuals and families get material resources from their income, which influences their purchasing power. As a result, income contributes to the resources needed to maintain good health. It may be more relevant to examine the correlation between income and health by looking at how much of one's income is spent on things that improve one's health. When coming to women's health, even if they earn more, women prefer first to look after their family. How we need to observe what is the priority of themselves, whether they are spending more on health or whether they are preferring more on the family members. So other aspect is influence of cultural factors. Cultural factors include gender bias. Gender bias is the main reason which contributes for sickness in the women, because there are many prejudices observed daily. There are many prejudices faced by women. It is discovered that cultural norms, socio-economic position, health expenditure cost, sickness perception directly affected gender discrimination and access to healthcare services in India. And the other aspect is women's autonomy. Women with a high degree of autonomy at home were more likely to use maternal health services than those with a low level of autonomy. Women who engage in decision making at home are more likely to have better control over their health care, which may reduce the risks related to
Madam,
their.
you have another 2-3 minutes.
Yes, ma'am.
You have another 2-3 minutes. Okay.
Yes.
Yeah, thank you.
And there are taboos related to food during pregnancy. There are different taboos. What I observed from literature review, in many cultures and faiths, there are food habits and eating habits played a significant role in the health of the people. So food in certain Indian cultures, food perceived as hot is harmful to pregnant women, whereas food viewed as cold is beneficial. So there is a uniform impression of all animal foods like eggs, meat, fish as hot, and milk, yogurt, and buttermilk are considered cold in Gujarat, Tamil Nadu, and Uttar Pradesh, but as hot in Karnataka. Through this analysis, we can say that they lack nutrition by not eating certain foods. They consider themselves as hot and cold foods. So it leads to lower nutrition levels. And the conclusion, finally, long-standing discrimination against women in many aspects of their life has resulted in a greater recognition that women's status is essentially in their capacity and desire to manage fertility. There are different factors that influence women's sense of personal safety as well as their reproductive decisions. So we need to observe women's health in relation to variety of demographic and socio-economic, cultural, behavioral aspects. So there is a need of systematic understanding, coordination, and cooperation among different departments in the implementation of public health policy. Thank you. Thank you, ma'am.
Thank you, ma'am. Thank you so much, Dr. Harita. So that was indeed a very good presentation.
Thank you, ma'am.
We will move on to the next presenter for the day. We have with us the next presenter, Dr. Vasanta Gauri, Assistant Professor, Sri Vaishnav Vidyapeeth Vishwavidyalaya, Indore. And her topic is on handling natural disasters and resilience building, a study in South Asia. Over to you, madam.
Thank you, ma'am. Thank you very much. Let me share my screen.
Yes.
I hope I am audible.
Yes, you are audible.
Okay, thank you, ma'am. I'm very thankful to you, to the organizers, and for giving me this opportunity. I'm basically from Osmania University only. Under the guidance of Ravinder Kaur Madam, I have submitted my postdoctoral thesis on public administration. Here in this August gathering, I represent Vaishnav Vidyapeeth Vishwavidyalaya, where I am working as assistant professor. Now, my topic for today is the handling of natural disasters and resilience building, a study in South Asia. No, this is not a research paper, not an empirical paper. It is based on secondary data. It's a review paper. So I have tried to analyze how better the natural disasters can be handled so that people can be protected from these disasters. Just a minute. natural disasters are, as you all know, it is a part of the nature. They keep reoccurring, and depending upon the geoseismic changes in the particular regions, they are often devastating. They cause a lot of destruction, earthquakes, floods, volcanoes. All these are types of natural disasters. Only these disasters can be prevented only with clear strategy towards their prevention, how they can be mitigated and protect the country from its ill effects. It has to be properly planned by the respective countries. At the same time, there needs to be a network building among the countries so that these natural disasters can be avoided by all the countries. Now, these natural disasters are particularly prone to South Asian countries. It's because of the geographical setup of South Asia. South Asia is its setting makes it particularly susceptible to natural disasters. For example, this global risk index, it has evaluated the 173 countries in which Bangladesh was ranked 6th, Pakistan 66th, India 71st, and Nepal 99th as a risk-prone positions. Then this index declares Bangladesh to be the second most risk-prone region only after Philippines in Asia, and it is sixth in the world. Now, covering 7 nations means these people have excluded Afghanistan. So they have covered 7 nations: Pakistan, Bangladesh, Nepal, Bhutan, Sri Lanka, and Maldives. South Asian disaster report that was published in 2005 described South Asia to be neighborhood of disasters. Then common problems. First, analyzing about South Asia, we need to understand what the common problems are there in South Asia. Poverty, it is home for 29% of world poor. In India also, still we have 13% of people living below poverty line. Then there are gender differences and illiteracy. Now, this adult literacy rate in South Asia is low when compared to the other parts of the world. 76% of men are literate, whereas women are 62% literacy rate only is there. Now, this is affected by the accompanied, or rather I can say by low participation of women labor force. That is 25% only are participating or employed somewhere, whereas males are 74%. Then corruption. As far as corruption is concerned, the Transparency International indicates that no country in South Asia ranked below 50 except Bhutan. Now, though India improved its position, but still it scored 85 in 2021, as well as 22. Then other countries like Bangladesh, Pakistan, Sri Lanka, all of them have ranked scored above 100. That means they are more corrupt. Then other problems like environmental degradation and pollution. As far as air pollution is concerned, in South Asia is the home for most polluted cities. Okay, like Delhi, Lahore, Dhaka, and Kathmandu. They are in top 10 positions of most polluted cities in the world. Asian food security is threatened by deforestation, diversification of land resources. Nearly 75% of South Asian original forest cover is destroyed. This is because of the urbanization and deforestation, all these things. Then and as a result of it, you can find there is increased global warming as well as climate change. Impact of climate change can be explained in many ways, but one thing only I can say, that environmental degradation has reduced the capacity of ecosystems to act as buffer against the climate change. And for this reason, we have repeated natural disasters, repeated cyclones, repeated earthquakes, unexpected disasters taking place all over the world, particularly South Asia. Then other problems include water resources problem in South Asia. Now, the greatest Indo-Gangetic basin, which is there, 60% of its groundwater salinity is increasing, arsenic effect and salinity. As a result, water is unsuitable for drinking. Then migration is happening due to climate change. Millions are displaced because of the erosions, because of the coastal flooding and all these things. Migration is taking place because of climate change. And migration from Bangladesh, we can observe people migrating from Bangladesh because of climate change, and it is causing conflicts between the countries. Then infectious and non-infectious diseases. South Asia is home for all the infectious as well as non-infectious diseases. diseases. There are social stigmas attached to the infectious diseases like AIDS. Then resurgence of TB can be observed in places where there is a lot of public, where people live in dense areas. And then 98% of children 98% of children who die out of pneumonia also live in are from South Asia. So South Asia, we cannot forget about the situation of South Asia during the COVID-19. India, Pakistan, and Bangladesh, these were the three nations that took over China in terms of the number of COVID cases. And during the second wave, particularly, we have seen in India, acute scarcity of oxygen led to the death of families together. Then natural disasters created havoc in the lives of common man in the past 30 years. I have just tried to collect the what kind of at what scale the disasters have led to loss of life. That is tsunami 2004. It has killed almost 275,000 people and 14,000 went missing. Then this tsunami which occurred in 2011 in Japan, it occurred because of the earthquake of 9.0 magnitude, and it created a lot of devastation. It also led to the Fukushima nuclear accident. Afterwards, notable cyclones and floods which are being observed 2017, 20, 22, probably in 22, the floods of Pakistan, we cannot forget. They have created a lot of disasters and a lot of loss of life as well as property. Then as far as the disaster management is concerned, there are 4 components of disaster management which have to be concentrated, which have to be taken seriously by all the countries in South Asia. That is the mitigation of disaster, preparedness for disaster, response quickly, and recovery. Mitigation, as far as possible, try to avoid the disaster. If it is a hazard, at the hazard level only, try to see that climate change consequences should not be repeated. Try to avoid the consequences of climate change. Therefore, try to increase afforestation and all these things. Then preparedness, it involves that people should be, governments should be prepared for disaster prevention, disaster avoiding. Then even if the disaster takes place, a quick response can probably save many lives. And finally, the victims that are involved in are affected by disasters, they should return to the normal life, and that way the government has to take measures. Then in South Asia, what are the common agencies or common institutions that are working for disaster management in South Asia? Actually, this is a major problem that I have noticed, that in South Asia is having its own governance system. That means each country is having its own governance systems, and they do work on disaster management, but they work unconnectedly. There are certain institutions established exclusively for South Asian development, like SARC, ASEAN, of course, it is Southeast Asia also is covered, and then ACD that covers both South Asia and Southeast Asia activities, and then ECHO. These are actually established for the sake of mainly not disaster management, but the trade activities, to improve the trade activities within the South Asian countries. Then SARC Disaster Management Center was set up. It was set up in India only under the premises of National Institute of Disaster Management in Delhi, and its global assessment report on disaster risk reduction indicates the risk reduction strategies in global arrangements. Then Asian, of course, is having many agencies like Asian Association of Disaster Management and Emergency Response, Asian Humanitarian Assistance, Asian Regional Program on Disaster Management, and then Asian Regional Disaster Emergency Response. There are many associated with Asian. Then Asian Cooperation Dialogue, it was created to integrate the cooperation of the regional organizations of both SARC as well as Asian. Then finally, not the least, we should not forget about United Nations International Organization, Disaster Relief Organization, also assists in regional organization disaster relief operations. Then these are some of the organizations that are working for a common cooperation of the South Asian nations disaster relief activities. Then India is nowadays emerging as a global leader in the disaster relief measures because of the disaster response force, that is National Disaster Response Force, that was initiated, and it included paramilitary forces. At the same time, state disaster response forces, they draw from the home guards and civil defense. So they are very well able to go to other countries also, like they have gone for the Nepal, they have gone in Turkey, Syria also recently for disaster relief operations. Then the recent CDRI, Coalition for Disaster Resilient Infrastructure, that is launched by the current Prime Minister Modi ji at UN Climate Summit in 2019, and it is grouping almost 36 countries along with United Nations and other multilateral agencies. So this year, during India's presidency at G20, the CDRI has been included in the working group deliberations also. So India is already ahead in managing the disasters, whatever disasters are happening. For example, the Yash cyclone that appeared, that took place in 2021, and the recent Biparjoy cyclone, we can say that proudly that minimal loss of life occurred. Of course, a lot of loss of property will be there because it is immovable, but at least lives can be protected. Then to conclude, I can only say that most of the South Asian nations are poverty-ridden. They have mutual rivalries also. They have boundary problems. They're sharing water and other historical, social, economic, ethnic issues. Now, it is very difficult to keep them united, but then unity is required for cooperation, for networking, and also effective disaster response and management. So steps must be taken to enhance cooperation between all the stakeholders involved in this disaster management and resilience building in South Asia. There is a need to strengthen the existing common institutions, therefore, and then to make it binding on all the South Asian nations that they have to listen to these common institutions. They maybe then perhaps the future, whatever disasters occur, they can be better they can be better reduced. The risk can be at least reduced. So my suggestions are that disaster risk reduction and climate change adaptation needs to be promptly integrated in the national planning process of all the South Asian countries. The response and mitigation efforts of these common associations should be immune to this is very important, mutual rivalries of its member countries. Now, place additional pressure on the member countries by legally binding the targets on greenhouse gas emissions and to prevent the disaster climate change situations. Then usage of big data, usage of digital identity system, risk analysis, geospatial data reduces the barriers in information to include and empower the risk-prone communities. Countries in South Asia have committed themselves for SDGs by 2030. Now, in order to ensure that no one is left behind, governments across the world must implement the risk-informed policies by investing in these emerging technologies. Local groups, finally, the local groups in the disaster areas in their particular countries, they should form associations, we network with disaster management teams and work for effective resilience building. Then Asia Pacific Disaster Resilience Network should also, this belongs to UN, should also make serious efforts to pool and strengthen the regions to address cross-border or cross-boundary disaster, as all the countries in the region of South Asia are adjusting to the climate change. I mean to say they are adjusting to the climate change in the sense they will have to experience further disasters probably. So only one thing can be done is preparedness. Be prepared or reduce the risk of disasters, prevent anything that is unnatural, that is don't cut, no deforestation should take place, no further urbanization, deforestation, all these things are leading to natural disasters. So these things have to be reduced. That's all. Thank you. Thank you.
Thank you, madam. Thank you. Thank you. Thank you so much.
Thank you.
That was a very good presentation on the disaster, because it's a need of the hour. Now the weather is also changing. We have a lot of climate changes. happening
Yes.
everywhere. So this is one of an important topic that we need to focus upon too. Thank you so much for this.
Thank you, ma'am.
And the last participant for the day is Dr. A. Amuda, Assistant Professor from the Department of Public Administration, Anna Adarsh College for Women from Tamil Nadu. And her topic is on social inclusion perspectives of Indian medical education under the NEET system. Over to you, Dr. Amuda.
Thank you, Dr. Meera. Good evening, Sodhi sir, Saurabh sir, and Sabu Thomas sir. My topic is social inclusion perspectives of Indian medical education under NEET system. Medical education plays a crucial role in shaping healthy societies. Efficient and well-trained medical professionals ensure maintenance of public health and consistent quality delivery. When it comes to India, there are severe disparities with the availability and accessibility to medical care provision across rural and urban areas. Moreover, regional disparities among the number of students qualifying the prestigious National Eligibility Cum Entrance Test also reflects lopsided dynamics. On the other hand, studies estimate students pursuing medical education from the present system tend to look for individual goals and migrate outside India for better career prospects. If we consider the rural-urban divide, urban center take the lead in total number of aspirants qualifying and pursuing medical education degrees after NEET. Reading these insights together create a connected picture of India's existing medical system and its imminent future. In this paper titled Social Inclusion Perspective of Indian Medical Education under the NEET system, 3 factors have been analyzed to see how medical education system in India currently operate. First of all, the colonial roots of Indian medical education framework has been revisited. In this regard, the higher status given to Western medicine and its limited access to Indian students have been assessed. Secondly, the influence caused by one-size-fits-all policy of centralized national-level entrance exam in the form of NEET is reviewed. Thirdly, recommendations are evolved to help to reshape the existing medical education policy in India. In 2013, Medical Council of India introduced National Eligibility Cum Entrance Test, which was to be a national level and only medical entrance exam for admission to medical and dental courses in India. After debating in 2013, the exam was discontinued and did not resurface until 2016. After it was conducted in 2013, the Supreme Court of India put a stay on the exam in response to petitions received against the exam and said that MCA could not interfere in the admission process. The exam made a comeback in 2016 when it was conducted twice, once in May, which was considered the first phase of AIPMT, and then in July, which was considered the second phase of AIPMT. This AIPMT completely replaced by NEET in the year 2017. Along with AIPMT, medical entrance examination, which were conducted at state level, also became a thing of the past. When this happened, the only criteria of selecting students to undergrad degrees in medical education course turned out to be the mark students scored in the NEET exam. And the objectives of my study is to assess the entrenched influence of colonial frameworks in India's medical education institution. It has been assessed to see how they have led to stagnancy and gatekeeping of resources that judicially belong to the nation's population. The second objective is the focus on how the UGC NEET exam model has enforced the exclusivity of medical education, turning it to a sign of prestige instead of essential public service it should be. Third objective is it shed light on the need of a planning and policy development in the domain to have its rooting in the morale of social inclusivity and erasing regional disparities. The methodology adopted, descriptive analysis has been made to study the evolution of the India's medical education system under British rule, and quantitative analysis to understand the disparity between education performance indices and the number of qualifying students state-wise. And the statistical study is used to study the disparity in availability of specialized medical professionals in the rural areas of India. Through this descriptive analysis, some of the text which was studied by the researcher is text like Public Health in British India, a brief account of the history of medical services and disease prevention in the colonial India, a history of Calcutta Medical College and Hospital, and colonizing the body, state medicine and epidemic disease in 19th century in India, were referred to create a clear understanding how colonial influence shaped the medical education domain in India. And through this quantitative analysis, Niti Aayog's Education Performance Index reports, that is 2015-16, and NEET exam result data over the year-wise were analyzed in order to recognize how top performing states in educational domain produce results with respect to NEET exam. And with regard to disparity in availability of specialized medical professionals in the rural area of India, newspaper reports and committee hearings headed by former Justice A.K. Rajan was analyzed to assess the shortage of medical professionals in the rural areas of the country. And when it comes to India, the evolution of modern medical science in the country is heavily tainted by the color of colonialism. Since colonial power focused on economic exploitation of the provinces, medical science was considered as a private matter and not a public service. Native Medical Institution, which was started in Calcutta in 1822. This institute focused on providing systematic medical training to Indians in the vernacular medium. Accordingly, the study consisted of mix of translated European works on anatomy and surgery, along with coursework on indigenous medical system of Unani and Ayurveda. After 4 years in 1826, Indian Medical School was inaugurated in southern Bombay to further provide Indian students with opportunity to learn Western medical education. The next decade saw a total revamp of education system in India as a struggle between Orientalists and Modernists led to the indigenous system of education losing their colonial patronage at large. Accordingly, Calcutta Medical College was established in 1835 to rejuvenate medical education dynamics in India. Over here, Indian students were instructed in the complex theme of Western medicine, which helped them to inculcate the cutting-edge skills and techniques required to perform surgeries and medical care as prescribed under Western medical science. Hence, only privileged class people could study and propagate Western medicine, which was considered as modern and supreme in comparison with indigenous systems like Ayurveda and Unani. Based on the quantitative analysis, it is analyzed that Niti Aayog report of School Education Quality Index showed South Indian states of Tamil Nadu and Kerala as top performers in the education sector. But on the other hand, total number of registered students clearing NEET exam from these states were lower in number. South Indian states had a lower than 60% passing rate in NEET exam, while Delhi, Haryana and Chandigarh had more than 70% of students they have cleared the NEET exams. Analyzing the finding with A.K. Rajan's report on how NEET exam excludes the poor, it becomes clear that the economically privileged section of the society gets an unfair advantage here. according to the report, NEET exam failed to assess the students' practical insights in the core subjects of physics, chemistry, and biological science. With regard to disparity in availability of specialized medical professionals, the finding is medical institutions providing specialized care are presently concentrated in urban centers, while rural areas are allotted with primary health care centers. However, independent research on the availability of medical professionals in primary healthcare centers shows that qualified professionals are unwilling to spend their time in public service for the rural people. And also, India still grapples with shortage of medical staff, because the increase of the doctors in rural primary healthcare center is 17.5% in 2005, which is increased to only 21.8% in 2021. With regard to specialist in rural community health centers, it is only 46.7% in 2005, which is increased only to 68% in 2021. With regard to auxiliary nursing midwives at PHS and subcenters in rural areas, only 4.7% in 2005, and it is increased only to 27.2% in 2021. In conclusion, I would like to conclude that a cross-analysis review of medical colleges from different states can help to understand the disparities lying in terms of quality of service delivery, deficits in personnel and resource availability, need for development and expansionary measures wherever required, and an overall assessment of the state of medical education in India. And also understanding the inbuilt economic bias and gatekeeping caused by the NEET models has to be analyzed with the help of social scientists. Furthermore, their research findings have to be translated into valuable inputs in policy device with the help of efficient policy makers in the bureaucratic tier. Creating quantitative assessment to see how to improve the acceptance rate of medical students from rural communities will help in the availability of specialized doctors in rural primary health care centers. According to World Health Organization, creating efficient medical professional is the ultimate solution to create a healthy society. As the world's most populous state, India should take lead in this cause and set example as an upholder of social justice and equality while pursuing for better quality standards. Thank you.
Thank you, Dr. Amuda, for that lovely presentation. So I think we have seen a lot of presentations for the day, right from maternal health and the evaluation of Pradhan Mantri Matru Bandhana Yojana, and then cultural factors that can affect the women's health, disasters, and then absolutely the NEET system. So I would now request our chair, Dr. Inderjeet Singh Sodhi, to pass on a participants. Thank you to all the participants for giving us a very good input on various topics.
Good day. Thank you, Dr. Meera.
Thank you, sir.
All have done very hard work, and I think everyone was enjoying the presentation because all have done their best, and all young, particularly young blood is there now. So young blood always have some energy, capacity, and they have put up good data. I am very much happy. And I think out of two are from the Osmania University, and 2 or 3 are from Punjab University, Chandigarh, Department of Public Administration. So good to see. So now, madam, question answer round.
Yes, sir.
Okay, good.
Questions can be posed by the participants also after your questions and remarks, sir. The chair and the co-chair, of course.
Yes. Yes. So any question, any comments from the participant or the presenter?
Well, nice presentations, and I think I have one or two questions. And maybe I should start from the last presentation. That's from by Amuda. Well, Amuda, it was a nice presentation, and you have done very well. But at the same time, I have a disjointer here. So after going through the presentation, I feel that you have taken NEET as a benchmark for educational attainment or quality. So the number of students qualifying NEET from rural areas, your argument is that is very less. And well, I think you have also to look into the other areas, maybe people joining ISER, NISER, IIT, or JNU, Hyderabad, these big institutions. So I think it's a bit problematic because we take engineers and doctors as, yeah, or being an engineer or doctor is to be the best thing in society. So you have worked on that assumption. I feel that it's a bit wrong assumption. So, well, the letter is okay, but the argument, the basic point is that we have to look back to the other factors also. Well, Amada, I think that you, when you publish your paper, you may be more specific on that. Amada, are you there?
Yes, sir. Yes, sir.
Yes, yes. So I think you got my point. NEET is not a benchmark for education quality. It's only for those who aspire to become a doctor. And being a doctor is...
Sir, India is a populous country. So there is need for more infrastructural requirements for medical education. And also evidence shows that we really need more medical professionals in the rural area. Rural area, we need more medical professional. But whereas we take NEET, no, not everybody, they are studying CBSE board. Some of them, they are in the state board. And those who have money only, they are getting trained with the NEET exams. But the students in the rural area, they are struggling. They are struggling to get NEET exam, to clear the NEET exam, because they are not getting the specialized coaching there. That disparity I felt, sir. I think this is my idea.
Okay, that's fine. But my point is that our rural areas, our society needs more social engineers, maybe more social scientists also. And being a doctor is, well, in early days it may be something good, but now we have a number of medical institutions. And in our part of the country, I think that being a doctor is a bit, now it's a bit dangerous because you can't get a good practice unless you are getting an MD or another qualifications or specializations. So maybe people may be a bit afraid to get into that kind of employment. Well, that's my point. Okay, that's fine. And I have a question to the presentation on natural disasters by Vasanta Gauri. Okay, madam, it was a nice presentation. And well, in the last point, you said that mechanisms like SARC and ASEAN should be strengthened to mitigate this kind of disasters. But as of now, what is the contribution of SARC and ASEAN as an institution to mitigate this kind of issues?
Actually, they began as a in order to build the economic ties initially. Disasters relating agencies in SARC and ASEAN, they were started eventually, not in the beginning, but later on. But I feel that more emphasis should be on these institutions because they are common in South Asia, so they can network with all the kind of governments and then put up a proper procedure for handling the disasters. It is possible for these institutions. Each country can manage, can prevent, mitigate disasters in their country only, but then disasters don't see the country limitations. They will hit all countries together at once. So for this reason, I feel it is very important that these institutions should focus more on disaster management, and then strengthen activities relating to disaster management, sir.
In that context, I also come across one of your conclusions, one of your suggestions. You are asking
Sir.
for legally binding protocols with regard to this disaster management. But
Yes,
you know, this legally binding protocols between nations is a bit, yeah, it's a bit difficult kind of thing, because you know there's issues of sovereignty, and international law itself is just an opinion. It's not a
Yes,
law.
sir.
So how you
I
can
understand, sir. But then legally binding, unless it is not done, nobody will listen to these international institutions. We know how much people listen to United Nations organizations, sir.
well, how we can make it legal in an
Yes.
informal situation, because even the UN is not legal in that sense, because it's an agreement from which you can withdraw at any point of time.
Yes, sir.
That's
So
a student
unless it is made legal, these wars and these fightings are also going to occur repeatedly. So some legal binding should be there. One institution which can control South Asian nations. Similarly, one institution which can control all the countries in the world, so that they don't fight between among each other like that.
But madam, as a student of political science, there's a problem. We are arguing on sovereignty as one of the basic elements of state. So you're compromising with sovereignty when you are entering into legal, you are being bound by some legal provisions.
There should be a midway, sir. Sovereignty should not be taken away, but at the same time, the countries should be legally binded. So anything that such type could be done in future, hopefully.
Okay, thank you.
Okay,
Okay.
sir.
I request all the participants to keep their cameras on at the end of the session so that we can click a picture. Dr. Saurabh, Sodhi sir is there?
I cannot see Professor
Yeah.
Sodhi. I'm calling him.
Yes, sir, please.
I think that the participants can shoot their questions. Yeah.
Yes, the participants, if you have any questions on any other paper presentations, you may please post questions. I can find some of you have come to attend also, so you can also post questions. I think Ms. Asha Lakshmi, Ms. Reena Kumari. So if you wish to, you may post.
With the permission of the chair, I would like to ask a query. I have a gentle query.
Yes, sir.
We are currently evidencing the questions of the agility of the institutions. There are a lot of papers which are focused on which are talking about the policy response to the health policy, particularly the maternal health. So how the agility of the institutions, the infrastructure can be improved. If any of you can share your opinion, it will be wonderful for all of us. Because without the institutional capability and the agility, the current challenges cannot be met. So how to improve it, how to emphasize on that particular aspect of the governance?
Yeah, so I would like to answer this query. So we need a separate postnatal care intervention for that, because we need the funds to improve the infrastructure, and we can only have the funds when we have once we have a separate scheme. So that scheme should focus only on the postnatal care, a separate scheme, because this is the area where we are lacking in the maternal health, and we need funds also for the medicines, for the infrastructure, and for the consumables. So that is very much required. So a separate scheme is required where the socio-economic measures, where the infrastructure measures and the policy measures, they should be all integrated. So only then effective postnatal care is possible.
Thank you so much. Our chair, Professor Sodhi, has joined. Sodhi sir, are you here?
So, sir, you may please ask them questions and give your remarks, sir. Sir, can you hear me?
Yes, I can hear you. Yes, Meera.
Yes, sir.
So I should question answer round is over, I think. No question answer.
Questions. Sabu sir had asked questions. Now it's
Only
your
Sabu sir.
turn.
Only Sabu sir.
Sabu sir, and of course, Dr. Saurabh also asked a question. So it's your turn, sir.
That means mainly the organizer have asked, but no paper presenter have asked question from each other. That means all are satisfied. It means either or they are satisfied with their own presentation.
Sir, I have one observation with respect to maternal health and nutrition. I'm Asha Lakshmi from Central University of Kerala.
Yeah, most welcome, madam. Yes.
See, I have one observation that we have a number of policies and schemes with respect to improving the status of women and maternal health and nutrition. But whether women are aware of it, that we have to check, especially the status of tribal people, tribal women. So actually in between, we can say that in between the policies and the actual implementation, theoretically, we can say that in the technical terminology of public administration, we can say that there is the presence of formalism. There is a gap between the policies and their actual practice, because these people are unaware, especially the tribal women are unaware of such policies. So what we need is we have to promote health literacy in that way. That is whether these people are aware of health policies, whether these people are aware of schemes related to maternal health and nutrition, to whom shall they approach, which are the institutions that are providing these facilities. These should be taken up by, such a campaigning should be taken up by the local self-government institutions, and their enthusiasm and political will is very much necessary in order to popularize these health policies and schemes for women. That's my observation. Thank you.
Thank you, madam.
Ma'am, I would like to respond to ma'am's observation. So that is what I mean in my presentation. We need some policy channelization measure. We need to see a way we can integrate the feedback, because a lot many things are going around. ASHA workers are giving feedback, the doctors are having some feedback, but it is not reaching the infrastructure, at the structural level. So it is not getting integrated at various levels. And we also need a proper evaluation of the policies at the level when they are complete, and at various levels in between the policy implementation stage. So we have the institutional measures, we have the socio-psychological measures, but all these things are very aloof. These are not very much integrated, or if they are integrated, like the people do not know about it. There is no structure for all these things. So that has to be done in a very good ways in order to achieve like effective maternal health.
Okay, can I just pose a question? Because since Ms. Asha Lakshmi and Mrs. Vijayata Sharma, both of them have stated regarding the policy, you talk about the awareness measures will have to be taken. How do you think we can reach out to the people? Because there are ample policies and schemes available. We always think about this awareness, but then how can we reach out to the people at large? Any suggestions on that?
So at the grassroots levels, we have the panchayats, we have the local governance, which is into operation. And under the NRHM, there is a provision of ASHA workers, which are the community health workers. So they remain in the community only. So they are a good link between the institution, that is the health center, and the people. So if we like give them a proper education, proper counseling, like how to do the work, what they should do, it is already going around. But then there is also certain other factors, like caste factor is there, location factor is there. Sometimes the ashas, they are not satisfied with the pay that they are getting. So all these things are also retarding the measures that is being proposed by the government. So these things should also be taken into account, because they always play a role and affect the outcomes. So that is what all these things should be seen in a very good manner. Like what are the why the ashas are leaving? There's a lot of attrition among the asha. So ANMs and ashas, they are doing the strikes. So most of the time they are wasting and sitting at the DC office. And then the doctors, they are not available. So there are proper guidelines that the doctor should be available from like morning to evening. This is the timing. They're on long leaves. They don't like visiting the rural areas. So all these factors are there, like institutional factors are there, socio-psychological factors are there. So we need a separate policy on postnatal care, where we study all these things in detail and then come up with some recommendations and policy guidelines.
Thank you.
Madam, I would like to share my opinion on this, that it is my observation that a policy can only succeed if the policy education phase is taken very seriously. The policy implementation is done, but if the policy education that makes the beneficiaries and all the stakeholders that are involved in the policy process, if they are not at all aware about the policy, not aware about the policy statement, the policy cannot succeed. And in third world countries, this is a major drawback and a setback, that policy education is not taken very seriously by the governments. Policy may be formulated very nicely, but if the beneficiaries, for example, the ASHA workers and all the stakeholders for whom the policies are being formulated, if they are not aware, if the implementing agencies and the governmental departments which are involved in the implementation of that particular policy, if they are not aware about the objectives, goals, and the policy statement, then the policy, it is very difficult for the policy to succeed. So the policy education is the key for, in my opinion, for the success of any policy, whether it is a health policy or policy drawn for any particular sector of the society.
Yeah, rightly said, sir. So the political and bureaucratic structures, they should align, and they should also cooperate with the think tanks, research agencies. So I think that should be done in a very good way, because there is a lot of political role in this. So policy awareness will be done once the policy comes to the panchayat, and they have to propagate it in a right way, like who are the people they select. They should ask the asha, or they should ask the punches, or they should select some other people. And also like how that would be taken by the villagers. So whether there is a restraint to it, or whether they will follow what is being said in the policy, that would also depend upon what the outcomes we would be able to achieve by that particular policy.
And
Dr.
one more
Saurabh,
thing.
yeah,
Yes,
Saurabh, I would like to add a point here. I feel that in India we have a very strong mechanism for policy education. We have a very strong and well-equipped public information department, which is operating through a very wide and educated network of people recruited through the Indian Civil Service. So the mechanism is there. How it works is another thing. But I think we already have these mechanisms, and they claims that they are 24/7. They are working on these modalities. But where we are missing this education, that's a question. So we have the mechanism. I think already we have developed a very good network. The public information department is PIRD is actually their mission is this. I think is policy education.
Yes, sir, I completely agree with you, but how far they have been able to succeed in their purpose? of establishment? That is also a question for us to assess. And that one more observation of mine is that we are talking about the local government institutions like the Panchayati Raj institutions, how they are performing. Particularly in the southern part of the India, we can see a good performance by the community institutions and community clubs and community groups, particularly the local government. But when we talk about the northern part of India, we will see a different picture. So how far we have been able to strengthen our local government is also a question that we have to assess. We are talking about
and also the cultural factors, they also play a greater role. So policy effectiveness also depends upon the perception of the people, also the personality, also the family mechanism, the relation between the daughter-in-law, mother-in-law, and their husband, whether they would want their daughter-in-law to go for ANC or PNC. So that has a major role.
Yeah, but then don't you think that policy would be a successful one if we get a proper information or a proper feedback from the people? Because that is most important. We have ample schemes and policies, but people, though it reaches them, even if we have to refine the policy and a lot of tasks involved, it requires a participation from the people also for that to be successful. And there is a lacuna in this particular area because people never volunteer to state whether the scheme is good or not.
Very rightly said, ma'am. And that feedback that should also be integrated because it remains there only as mere discussions. So that is being going on.
I would like to add one more point to everyone. Actually, in Telangana, especially in Telangana, there are different programs like KCR Kit and Amma Odi scheme. Previously, Adilabad district in Telangana especially had highest maternal deaths. It was the highest number. Slowly, it got reduced with the introduction of these schemes, KCR Kit and Amma Odi scheme. These schemes are motivating some tribal women also to go to public health centers to and avail health services because of cash incentives, and they are providing all essential items, baby soaps like essential nutrient eggs, food nutrients, eggs, milk, and they are also providing all baby essentials and also mother essentials in 16, especially 16 essential items are provided in KCR Kit scheme. So it is very successful. After these schemes, maternal deaths slowly reduced in Adilabad district. So it is reaching out. These schemes are very having positive impact on women, especially on tribal women also. What I observed in Adilabad district is majority of tribal people. So this awareness is created by ASHA workers and NGOs, and they are getting motivation because they are getting cash incentives and also essential items. So they are visiting public health facilities. So it is very positive influence in Telangana.
I think urbanization makes a difference where mindset of the people actually differ, and so does the consumer behavior.
Yes.
Right? Because people in the rural area, they are just bold enough to speak about the policy and the schemes. But when urbanization happens, people refuse to talk more about it because they know what the situation exactly is. Right? So, but that's a nice input that you have given us about the ASHA workers and all that. It is absolutely good. We take that too.
Thank you.
And one more query I have. One question came in my mind. Debureaucratization can be helpful in this whole arena. Are there issues of bureaucracy or
Debureaucratization in the full arena? Okay.
in this health sector?
Yeah. Views of the participants.
Because
Madam,
we talk.
I think you have to unmute, Madam Asha Lakshmi.
Yeah, right. Pardon, please, Dr. Saurabh.
Yes, madam. I was seeking observation from all of you that whether a deep bureaucratization can be helpful in this particular sector of health, because we talked a lot about the infrastructure and the policy, but the people who are working in this sector, who are working in the system, whether we need to work on that human resource as well, or there is no need at all.
Debureaucratization in a way that that's actually, I would like to say that now the term administration is espied. Now we are making use of the term governance. Governance is getting wider attention because of the presence of numerous stakeholders. It is an umbrella concept. Along with the state, there are voluntary associations, there are political parties, there are media, there are private institutions. So in that way, we can incorporate voluntary associations too, in order to actually act as a channel between the government and the people, especially with respect to the services related to rural areas. Because otherwise, the burden on the shoulders of the government will be increasing.
So the Department of Health or the Ministry of Health is no more functional?
It is functional. In fact, it is functional. But with respect to ASHA workers, we can say that there are a good number of issues, especially with respect to their remuneration. They are getting only 6,000 per month. Only 6,000 per month. They are not satisfied with their remuneration. They have a laborious task to do. They have to reach each and every household. Compared to their task assigned, their remuneration is less. So we have to listen to their grievances too. That's one aspect. Then one more thing, inclusion is needed with respect to health sector. In Kerala, we have a good model with respect to education and health sectors. It is well known for Kerala model of development. It is also under wider contemplation. There are some criticism against Kerala model, but some areas are left in fact, because inclusive health governance we need. Still, people in tribal areas have to travel a lot of kilometers in order to meet a physician in person. So in that way, we have to include tribal people. So that inclusive development has to be achieved in the context of health services. So that is to be achieved. But with respect to education, we have almost achieved that. But we have very good primary health sectors, primary health centers in the state, but limited tertiary health sector development. Primary sector is very good with respect to the scenario of health. Compared to other states, we have a better status compared to other states. But one issue is there, inclusion. Issue of inclusion is still there. That's one thing. Then with respect to ASHA workers' issues, they are facing a lot of issues, including their remuneration. During COVID time, they performed very well. ASHA workers and Kudumbashree workers, they were in the task of stabilizing the society during the lockdown days. They were the stabilizers of the society during the lockdown days. But they have very limited remuneration. These things we have to address. Thank you. These are my observations.
No, wonderful observations. I completely agree with you. Dr. Meera, we should proceed further.
Yes, sir. I just have one small query that came when she was talking. Just that little clarification, and then we'll go ahead with our chair's remarks for the day. Madam, you were talking about the demarcation between the governance and the administration with respect to the entire system, the process. How can you demarcate? How do you demarcate these two in this kind of a situation?
What I want to say is that Now the government cannot stay away from voluntary associations. It cannot stay away from private agencies, especially after globalization and privatization. There are multiple actors in the society. We should make use of their services. Now the corporates have corporate social responsibility, CSR fund. They have CSR fund. Then why can't we make use of the information collected by the voluntary associations or the civil society organizations? That will strengthen our governance. So governance is not only the task of the government, not only the synergy between the government and the citizen. It is a collective responsibility. Governance is a collective responsibility. In earlier period, government had to render all services to the people. Now the scenario has changed. Now the government can act as a catalyst. But at the same time, it has to look after the welfare of the people. Control should be in the hand of the government, but it can entertain. It can entertain the service delivery by multiple actors. In that way, it can proceed. We should incorporate the youth also at the regional level because they are very much energetic. Whenever we are meeting a calamity, we are making use of the energy and effort of the youth. During the normal times also, we can make use of them. They are the future citizens. So governance is a collective responsibility. In that way, we have to address and redress this particular thing. We are expecting that the government has to do everything. The government has to render services. Everything needs to be done by the government itself. It has limitations. Unlike private agencies, it has to address the entire society, not only the preferred customers. It has to address the entire society. So it will have limitations. What we can do, we can go hand in hand with the government system in order to help the government system, in order to help the governance. In that way, we can look for the help and support by the voluntary associations. We can look for corporate social responsibility funds. We can do a lot of things. And we can incorporate the youth at the regional level because they have enthusiasm and energy.
Okay, madam. Thank you so much. I think all the topics are actually quite debatable. That is how our discipline is enriched. So that is wonderful. We could share our knowledge and gain knowledge also from all the participants, the non-participants, and of course from the chair and the co-chair. Now, may I request our chair, Dr. Professor Indrajit Sodhi, to give us the remarks for the entire session. So you need to unmute, sir.
I'm unmute, madam.
Now you have. Thank you, sir.
I am thankful to Dr. Meera Rajiv Kumar. She handled moderation very planned way and within the stipulated time. So earlier it was not looking, but last 15-20 minutes was very lively and very vibrant. Everyone participated, even Dr. Asha Lakshmi, Professor Sabu Thomas, they have given their views and comments, as well as those paper presenters, they have defended as well as they have given their some arguments. I'm happy. I'm thankful Dr. Saurabh Chandra, who is the main organizer of this international 5-day conference. And he also highlighted some issues as well as pinpointed some challenging issues. There were all the 5 presenters have looked into from their own perspective. First presenter, Ms. Vijeta Sharma, research scholar, Department of Public Administration, Punjab University. She has very well talked about mental health in Punjab, policy response to postnatal care intervention. And she has looked at how there are limited studies on maternal health. No doubt, most of the studies, according to her views and observation as her review of literature, are on the basis of ANC and PNC. And particularly, most of those studies are also in Africa region. If we talk about other regions have not been covered so far. So that is very much needed attention, as she has highlighted. She also looked into A&M staff nurse as well as AMO, and she believed that there is inequity in postnatal care, which need urgent attention by all the government agencies. And second presenter, Ms. Neha Katoch, she is also from the Department of Public Administration, Punjab University, Chandigarh. She has looked into the evolution of Pradhan Mantri Matru Vandana Yojana, particularly in context of maternal health and empowerment. And she has looked into the development from the period onwards, 1997 to 2017. From that onwards, this scheme is renamed. She tried to give some points on the National Health Mission 2013 as well as Mission Shakti's Samarthya sub-scheme. So that was very relevant if we talk about maternal. Third presenter, Ms. Harita Saroop. She is a research scholar from the Department of Public Administration, Osmania University. Her supervisor is Professor Ravinder Kaur. She is very dynamic experts in the areas of public administration. She had talked about, Harita, on influence of social, economic and cultural factors on women's health in India. And during her presentation, she has highlighted, she believes particularly the social and cultural factor as well as demographic and behavioral factor, they affects the women's health and other related issues. Very nice presentation, Dr. Ms. Harita. And fourth presenter, if you talk about by Vasanta Gori, she is assistant professor Shri Vaishnav Vidyapeeth Vishwavidyalaya Indore. Whenever we talk about Indore, Indore is since last 6-7 years is the continuously the cleanliness city of India. And her paper was handling natural disaster and resilience building, a study in South Asia. Very remarkable study she has done, no doubt, on the basis of secondary data. And she has talked about many centers and agencies like SARC Disaster Management Center. And she has highlighted that poverty, social, economic, cultural, these all factors definitely affects the system in South Asia. But despite of that, there is a need to work together. And also she has looked into some technical issue, particularly geospatial data, as well as there is need to adjust climate change. Definitely that on that we have to look into, and all the international as well as national agency have to look into. The last presenter, Dr. A. Amuda, she is working at Anna Adarsh College for Women in Chennai, Anna Nagar. I have visited that college 2-3 times, and they have very good infrastructure and good team of faculty. She has looked into social inclusive perspective of Indian medical education under the need system. And she has looked into many up and down, particularly whenever you talk about need system, still there are many challenging issues. And from 2016 onwards, there have been some regular system if we talk about need as per her study, as per her views. And she observed that there is diversity in selection as well as NEET exam has excluded some poor students, particularly those who are not well-to-do or those who do not have proper resources for their selection. She also highlighted some cities, some state like Delhi, Haryana, Chandigarh, 70% selection. And in case of South India, there is less selection if we talk about NEET. So for that, there is urgent need by all the bodies. So I believe these all 5 presenters will send their full paper in the future, because I believe definitely Dr. Saurabh will bring out a good publication. Earlier also we have, whenever we had a time, we brought out publication in the journal as well as book form. So I encourage all the presenters, they should do at the earliest as per the guidelines, whichever will be sent by Dr. Saurabh and all the other organizers. I'm thankful to my co-chair, Professor Sabu Thomas. He has very handled systematically, and he has given some viewpoint that is definitely relevant for the present today's issue. And again, I'm thankful Dr. Meera Rajiv Kumar. She moderated very eloquently. Thanks, Dr. Meera. Everyone, thankful. Yes, Saurabh. Good. I think today's session was very vibrant. I'm very much happy.
Yes, sir. Thank you so much.
These young scholars have played very important role, particularly.
Sir,
Yesterday was the all
senior person. Today, totally young.
Sir, let me say that all the credit goes to you, because the chair was the youngest of the all.
No, no. All are young. Okay.
Yes, sir, that is why this session went so well.
He is
madam, please
vibrant. So don't spare the co-chair also. Co-chair
Yes,
also was
yes.
vibrant in his thoughts.
Thank you very much.
Yes, yes, of course, madam.
So both of them eliminated the entire participants and the entire program. Sir, may I request our Professor Dr. Sabu Thomas to give his remarks also?
I think that, well, I have nothing more to add what Professor Sodhi has already spoken. Yeah, we have a very vibrant session, and well, all these papers were well written and well presented. And they have answered all these queries in a nice way. And after that, we had a very vibrant discussion. So I think that we have a lot of issues to sort out, particularly with regard to the governance mechanisms, with regard to the governance part of the story. So at the end of the conference, I think we will come out with some results. So hope that all of us will contribute for this. That objective. Thank you. Thank you. Thank you.
Thank you, sir. Thank you so much.
Thank you.
Thank you, Sodhi, sir.
Thank you.
Madam,
Thank you.
group photo, madam.
Yes, sir, that's what I'm waiting for. May I request the participants to keep their cameras on so we can have a group picture?
Group photo on karo camera.
Should I say cheese?
Why not?
Yeah.
Cheese, butter, anything is okay.
Okay, ready? 1, 2, 3. Say cheese.
Done.
Done. Thank you so much.
Thank you. Thank you.
Thank you. Thank you to all the dear participants. And we really had a very good experience discussing a lot of topics for the day. And we explored a lot of topics pertaining to public administration and policy, with a lot of schemes which have actually enlightened us today. Thank you, all of you. And thank you, Dr. Saurabh, for organizing this so well. And also giving me an opportunity to moderate the entire session. And thank you, Sodhi sir, and thank you, Sabu sir, for your presence, which has actually enabled us to complete the session successfully. Thank you so much.
Madam. Thank you so much, madam.
Thank you.
Thank you.
Good night to all of you.
Good night, all of you. Thank you.
Good night.